We're gonna do markup and hopefully a possible vote on S30, which is, as you recall, the longest bill with the shortest.
Good afternoon, Jen Carby from the Office of Legislative Counsel. Yesterday, we had looked at a proposed amendment to S30. There are no changes to that, so just to remind you, that was putting in some language that had been inadvertently dropped from the version that was in the bill as an it because of some issues with what went into the electronic statutes. So this is restoring that. It is still in the green books as well. So restoring those two pieces. One was in lieu thereof, and one was this paragraph that begins the foregoing policy provision and ends with all caps incontestable. And that's it. We have not discussed any other, you have not directed me to make any other changes.
No, and this bill has been put out to almost everyone that would have comment on it. And we received no feedback. So should we walk through the original bill?
180 pages?
Well, or just briefly remind us of.
Could you at least like tell us what each section does or something?
All 100 sections?
I'll admit I have not read this yet because it's so long.
And I think in reading it's potentially more helpful for if you're looking to see what's actually happening to look at the marked up version, where I marked up from existing law. It was on your committee page a while ago.
Yeah. Look for it.
But just to understand what the actual changes are, because in the bill, as you're looking at it, all the language looks new. It's repealing the existing chapter and enacting a new one, but much of the language is unchanged, just reorganized.
Would it be called H95 S30 showing markup from existing law by Jennifer Carby?
That would be exactly it.
Just confirming. 213 pages.
Yeah, when I had the markup in it, it was longer.
How long, do you know how long the budget was this year? It might be longer.
So what, Madam Chair, what would be helpful?
I just want to ensure that everybody has a recollection of what we're doing, what is in the original bill as passed by Senate, not what was in it when I just what the bill is. H493?
No, it's not, that's 30, is it?
S30.
No, but it's the one you're
You got
looking
the
at,
original
what,
S30.
H490?
No, the one thing I'm looking at, I went under bill, committee bill S30 and found under Thursday, something, March something,
Yes,
Jen Carby.
March 20th.
Yeah. This is longer than the budget.
More words, less numbers.
That's true.
I would guess I can ask ChatGPT what's it called? ChatGPT to confirm it, but it's probably true.
Okay, so maybe I will pull up the some of the markup version to look at. Just by way of.
I'm gonna try an experiment.
I don't know what the best version to put up is.
Don't have a
I
keyboard, but
think that original marked up one,
Marked up one.
Existing law.
Yes.
just as a recollection of what we looked at last time.
Oh,
That would be on a committee page, right?
Yeah.
put up the color coded chart. All right.
Oh, Kristen, do you want to repost it
yeah.
on today's date?
Okay, here we go.
Okay, let's get this.
So this is the showing the markup from the existing law version. And so it has the section 1 that repeals existing 8 VSA chapter 107, section 2 that adds a new 8 VSA chapter 107, still about health insurance, but divides it, splits it up into subchapters that are in somewhat of a logical order, starting with some general provisions. The definitions section is mostly new, and now we would have definitions for the entire chapter, and the same definitions used throughout, so we don't have to keep defining health insurance plan. We don't have to keep defining health insurer. There's a new definition for major medical insurance. And this is really showing markup as though existing law was the underlying law, which it is, but showing what the changes would be and also where you can find the current law sections. So in some cases, there were no or very few changes. A lot of it is just cleaning up, whether it's legalese, like thereunder, and instead saying health insurance plan. And in other places, just making it clearer or getting rid of some of those different words to mean the same things. So we have, and we'll just go back to the other list for a moment. Just trying to pull up, just moving all around it is, sorry. I will stop my share. Just trying to get the list. Move things all around. Sorry, guys. I wanted my color-coded cheat sheet is really what I wanted.
It's really, they're very beautiful.
Yeah, very
rainbow ones.
Just because it reminds us what order everything is in. So let's see what I want to get rid of here.
This is the proposed changes to the color, proposed reorganization.
Right, that's just the organizational structure, so it's not actually going into all the words.
That's on Thursday, March.
Lord.
Yes, I somehow got rid of that tab, so not super helpful. Okay. Proposed reorganization. Yes, now I will put this back up. All right, so this is where we have our new subchapter organization here. So we have general provisions. Those are sections that kind of apply to in health insurance generally, just by the virtue of being health insurance. Subchapter 2 is policy forms and filing requirements. Subchapter 3 is group coverage. There are certain provisions that only apply to group coverage. Subchapter 4 is continuation and conversion of group health insurance policies, some of which is not applicable anymore because of the restructuring through the Affordable Care Act, restructuring of our market.
It's not applicable anymore, so.
Well, there's not as much in continuation and conversion of group health insurance policies
Oh, I see
as
what
there
you're
is
saying.
under current law.
Yeah.
Group health insurance termination and replacement, other forms of coverage, child and dependent coverage, internal and external reviews, required covered benefits, prescription drug coverage, prevention and treatment of cancer, and service delivery and treatment modalities. So those are all the subchapters within which there are lots of sections. And yes, as we had looked at before, sort of color coded it by where they were going to wind up before I started drafting.
Wow.
Oh,
Wow.
you should get a prize for this.
I know.
Thanks. Yeah, I need them to be distinct. And
This
that's
sort of stressed me out having to do all that.
okay, so we'll take that down, but just so that I don't have to run through each one of the subchapters to remember what they are. Okay, so then again, these are a lot of these are the existing provisions in their new order. So that you can see, what the former sections were, but they're now in the order that they appear in the bill. And so reorganizing, as I say, getting rid of legalese, getting rid of, for example, person, we don't need to include partnership and corporation because in Title I, the definition of person includes partnerships and corporations. So there's just lots of, that's from Citizens United.
I was just gonna say that.
So I don't know quite what to review in here, but it's just updating, reorganizing, modernizing without changing meaning.
I guess there are no changes that need to be made to anything on this that you feel other than the instance
Adding back
of
that
it.
language. That's right. I am not aware of anything that needs to be changed in here. It was shared with stakeholders a few occasions and has been, noticed on your agendas. There is a lot of, so many pages of amending the statutes, getting rid of gendered language, trying to think of what else, just using consistent terminology throughout. And then we have some updates, just conforming revisions to other statutes and other titles and chapters of Title VIII to reflect the reorganization so that all of our cross-references are accurate with the, just try to get down out of this into some of those, with a directive to my office to fix any more that we find, which we would do anyway, but it's helpful to have the directive. And then, oh my gosh, we're almost out of it. All right, conforming revisions, there we go. So then we started back at the very beginning of the titles with Title I and Section 3 and just updating statutory references throughout. And then after a number of pages of that, there is that directive that I mentioned to update any additional cross-references that I find. And then the interpretation and rule alignment with this, the changes in here being subservient to all the substantive changes you make. So for example, if you are amending in several of the bills that we're working on together, there's potential for changes to provisions of this chapter. I would make those updates to those to reflect the changes from that legislation in the newly renumbered Title VIII, but reflecting the policy changes. So we don't want it to be that because we're reenacting current law in a new chapter, that it's wiping out all of your substantive changes. So that's what it's saying. To the extent there's a conflict, to the extent I can make all of the changes, I make all of the changes. If there's a conflict, your substantive, meaning other bills, take precedence. And then we're maintaining the validity of rules adopted and orders, bulletins, forms, and guidance documents issued by various state agencies that refer to the current numbering system will continue to be valid until they can be updated or amended to align with the renumbering, and it would take effect on January 1st.
Everyone doesn't have to redo their forms
Right.
until
Everybody
the
doesn't
next due date report.
doesn't have to redo their forms. And because we are republishing Title VIII, Part 1 this year, it will all be in the new Green Book.
Anyone have any questions for Jen about this?
Other than so many.
Topper and then Brian?
When we make the statement that until something can be amended, there's no time limit or anything on that.
No,
So the other parts that were already there, they just remain in effect until
the parts that were,
infinitum and until somebody changes.
right. I mean, the rules and the forms are still going to be valid to the extent it makes things confusing. They may want to update their rules and forms and other documents, but there's nothing wrong with the validity.
Brian?
And there's no deadline said they have to, re-adopt all of their rules. That would be difficult.
I had a few questions I was gonna write down, but now I'm forgetting them. One of them, though, I haven't forgotten is, I'll probably remember the other one in a minute, is do you have any summary of mass changes? For example, like a list that says 40 times we change patient to cover 30 times we change benefit to insurance.
No, but I can.
I'm not asking you to do
find
that.
out. No, I have nothing.
Yeah, I'm not asking you to do that. I was wondering if it existed.
No.
Because if it doesn't exist, I don't know if we need it, but I was just curious because I'm looking through it and I'm like, okay, I see that one of the things is like changing patient or beneficiary. to covered individual. That's a change I
Or
see.
participant, or yes, subscriber or policyholder, yes, all these
Yeah.
different terms.
Yeah.
I mean,
Or like, so I've noticed like a few things like already, like a pattern. And I did try putting it in Chat GPT and it said it was too long, so I could do it section by section. Isn't that funny? It's never said that before. I could do it section by section and say, how many times did we change this to this? And it'll tell me without me having to count it myself. But like, the other question I had was, what is I'm scrolling like a beast here trying to
I
get.
took it down, so I stopped making everybody motion.
Yeah, it's torturous. I'm trying to figure out, so it's 8 VSA.
Yep.
Chapter 107, that's the only chapter we are touching here.
That is the only chapter we are repealing and replacing. There are provisions in other titles and chapters that we are making conforming revisions to
Yes.
reflect
Yeah,
the
yeah.
numbering. But yes, the only one that we are doing a wholesale repeal, replace is 8 VSA chapter 107, one chapter.
This is probably gonna like make people anxious, but I'm gonna ask.
Go.
Yeah, the question may make people, I don't intend to do this because I'm a member of the committee. And it would just be like bad form, but essentially anyone could amend anything in state law in chapter 107 on this. Because
As far as an amendment,
yeah, like they could come in and be like, I want to create universal healthcare by like, like amending. I'm not gonna do that.
I don't know. I mean, the end of the bill, the interpretation rule alignment gives the purpose of the bill being to update and reorganize the health insurance statutes. I mean, it would be up to the clerk and the speaker, but I think there's an argument to be made that anything outside of the purpose of updating and reorganizing the statutes
Would be very-
would be outside the scope.
But one could argue that.
You certainly, yes. I
Yeah,
think we can make
we're
that
updating it by
either.
deleting most of it and replacing it with like, universal healthcare, but I'm not gonna do that. I'm just pointing out that like, this is a
As
bit,
long as we can use your bill that's already on the wall, it's an amendment.
then you don't mind bringing it, yeah.
I got a bill up there too, Jim.
No, that's not the way to do it, obviously.
Yours goes in Title 33, so it's a different.
Yeah, it's not the way to do it. I was just pointing out that I don't think anyone is gonna think of that, but we just need to be prepared if someone decides, like, there's all these possible things I can try to amend here. I don't think anyone would dare, because healthcare policy, like, most people can't handle it. It tortures them. What, you have an idea?
No.
Yeah, you're right, though. You get my point. There's people there might be someone who's like, this is my chance to, make copays only $5. It's not in here. I know. I'm just using that as a safe example. Okay. The point though, is that this is I was asking you, is that this is an entire chapter
Yep.
of law in a title, within a title.
Yep. Exactly.
And then you are up, and then in addition to that, we are, not you, but like we, are seeking to amend all references to that title.
You are updating references to sections in that chapter that have been renumbered to reflect the new numbers.
So the ones that have old numbers, we're not updating.
So anything that in another part of statute outside of 8 VSA chapter 107, that refers to a section that is in 8 VSA 107 and and refers to it by section number, we are amending the statute that does the referencing to reflect the new number.
But only when the number is new. There might
Nothing
be,
stayed in the same spot.
nothing did. Okay, see, this is what I was getting at. I'm trying to understand the
Anything
scale of
stayed in the
change.
same spot.
So
Yeah.
any reference to a
Refer
sub,
back to the color-coded chart. If anything is the same color, let's see. Nope. There is. So anything that has, not the same color, anything that has in the current and proposed columns, the same number is in the same place. I don't think there are any, just because of how it's possible, but the
unlikely.
one that's a little bit confusing is 4062 became 4026, and we do refer to 4062 if I'm at, because it's the rate review, but it's just.
That's like a dyslexia, like nightmare. Sorry.
But no, a lot of provisions of the current law have letters after them. Most of our new provisions don't, because I spread out the span. So I don't think there's anything that kept its number.
Okay, but the main, I'm just trying to make sure I can explain it, even though I don't know who's recording this, is that,
Oh, dear, man.
I did, but then someone else wanted it, didn't they?
Oh,
But we'll get to that later.
I
We'll
think
get
that
to
someone
this.
else was you.
That- I just don't want to be, I want to make space and not just take space.
you should just read that,
Read what?
that color thing.
What do you mean I should just read it like, oh,
And then it tells you everything. that's
Read it.
I know, but what I'm trying to do is just get confirmation that what I heard, because I don't need to read that whole thing to do this, is that we are reorganizing an entire chapter of a title of healthcare law, and then we are updating any references to sections or subsections of that title in other parts of the law to reflect the updated numbers, because there are no numbers that were untouched by this generational
There to be.
revision.
I think you just wrote your bill.
Would you write that down?
No, I don't need to write it down.
You can go back and watch it.
Yeah, double speed like everything else. That was the fastest tour of a birth facility ever.
Ran through it.
Send me your.
I actually have just,
Survey.
so the act takes effect January 1st of 2026. Does, because I know that you wanted to do this over the summer to get it all into the new, so you're able to actually do that even though it doesn't become effective till January 1st of 26.
Yes, so I think from a really, and I will confirm, it's a good question. Let me confirm that with the publisher. I believe that all works out well because we're republishing the whole book. So from a really statutory revision geeky level, the supplement that goes with it that comes out in the fall will be huge because it will have the current version, which is actually kind of great for just, I'm going to hold on to mine. But it will have both the current numbering and the whole chapter there, and then it will have the new version. And they'll all be in one supplement, so it's gonna be a huge supplement. But then because we're republishing the Green Book, it will all get integrated into the new Green Book. I just need to confirm with the publisher. I think based on the timing of when things came out this year, it was not until after the first of the year, and so that would be my vision is that it would they would issue the new Green Book after January 1st, so we wouldn't have to have two versions of every single statute because that would cover the entire chapter, because that would defeat the point.
We don't want to make it just this actual take effect on passage.
No, because I think that's going to create confusion. That may create confusion in the field. Could we make it effective in, September, or October? I mean, for my purposes, I don't know that that matters, but it's a good question. So let me just confirm with the publisher what makes the most sense. I think that's a really good idea. I was trying to do it for, I don't think there's any insurers here, but I was doing it for January 1st just so that they could be, to the extent it affects anything they're putting in their language or in their documents, but we didn't change the standard policy provisions. That's the piece we're fixing, and which is what they base their actual policies on. So I don't know if it matters so much to anyone, but let me just do some checking around with folks. I think that's a good idea. And if you still want to get it out, we can change the effective date on the floor if you prefer, or you can hold on to it, whatever you prefer.
I think let's get it out.
I'll
And
see if I can get an answer this afternoon.
You could make it more interesting to have to change the effective date on third reading. People will be like, what is this committee amendment?
well, we already have one amendment to it, so there will be an amendment to the underlying strike all, right? I'm leaving that to the clerk.
Right, it's not a strike-all, but there will be an amendment to the bill. You're gonna have it, so you're gonna have a House proposal of amendment. No, we didn't do, we're still discussing,
Okay,
looking at the effective date.
okay. I'm sorry, does anyone know if Leslie's coming back?
I think she had to go to Senate Health and Welfare or
Oh,
something.
yes, she did. Okay, why don't we move on to S18 and we'll wait for Leslie to come back.
Okay, yes, and that's great because it will give me a chance to send an email to the publisher here and.
Okay.
Um,
And because we want you to have a strong committee vote on the floor.
This is gonna be the most interesting administrative, technical update presentation, I promise.
If you need any help with it, just ask me. I'll back you.
All right, let's move on to S18. So I originally we had scheduled this and I will say from the get-go that we've obviously heard a lot of testimony, thought we would go through it and sort of address some of the things, but then we had the Secretary of State's office come in this morning and they had some, and I think we should probably walk through what OPR had addressed with that, but I want to make sure we give Jen do decide to do any of that so that she can work on changing language. So that I wasn't anticipating that.
We're not doing S18?
We are.
Oh, okay.
Yeah.
great, sorry, just getting that.
We're trying to move it out today,
We're gonna wait until Leslie gets back and then we'll vote. Oh, S18?
or are we like just working on it?
No,
today?
we're just working on it today.
Just checking.
We're voting out,
We're gonna vote out S30.
but not the amendment.
No, we're gonna do the amendment. And then, although you said we could do a straw poll on the amendment,
Yeah,
and then we're gonna vote on the bill
as amended.
as amended.
Okay.
But I'd like to wait, give
Gotcha.
our other committee member a chance. So we might as well, since we're doing S18, let's move on to S18 while we're waiting.
Okay.
Is that what is that what you're asking?
No, I have my, yes, I have my sheet. I've got
Yes, you-
about Betsy Ann.
No, your clerk,
Correct.
the clerk did.
Yes.
We're up there then.
I know that. Yeah.
Okay.
It is our intention to vote S18 out though this week.
I would love to, if we
Okay.
can all come to sort of consensus on markup and that we give legislative council time to make any changes that we wish to make on it.
I hope we do. And all I would say is like, maybe we should give the last call for objection now. We're like, hey, by the end of this week, we're voting this out. If anyone has a problem, speak now, or
I think we all get that.
you did that right.
We did do that.
Okay.
So let's have Jen bring up what we have.
Yes.
And then I'm probably gonna refer back to the document that was given to us by Secretary of State's office.
Don't do that, don't do that.
Let me ask a general question of all the committee members. Is there anything that you feel like you want to know more about? Any more information that you feel like you're lacking? Any questions you still have? Because I can certainly have anyone brought in if you feel like who we've heard from so far isn't answering all your questions. I want to.
This is on the S18.
This is
right?
on S18. And I know we've had a lot of 8s and 2s and things like that. So this is the freestanding birth centers.
Okay, so here is S18. And we are still looking at the as passed by Senate, but you have now taken affirmative testimony, some of which I have written on my document just when you've heard from people. Some I have not. So S18 is an act relating to freestanding birth centers, and I did hear the testimony from Secretary of State's office this morning. I understand they have a proposed definition they recommend adding of low risk, what a low risk delivery is. Although I think theirs may have been more broadly on low risk pregnancy, so I think we might have to look at what they are suggesting, what you are wanting to do. Just in the way that they were describing it. I'm trying to remember now. Hold on, now I'm gonna pull up their testimony.
They had
Epidurals.
Uncomplicated
Yeah.
perinatal care provided to healthy patients during the childbearing cycle.
Right, so you, yes, thank you. So you have a definition of, or the bill uses the term low-risk delivery. This is a definition of low-risk perinatal care. So I think one question for you is whether you are contemplating a pregnant individual getting care from a birth center other than delivery for a pregnancy that is not low risk or is not uncomplicated. I think it just depends what term we're going to define or whether we need to change the language of low risk deliveries in the bill or whether we need to change the definition of low risk that you're adding. Does that make sense?
It does. I mean, my question when they were presenting this to us today is they've expanded this definition of low risk and it contains the entire perinatal.
Right.
And what happened, and I mean, to include the actual labor itself. So what if your labor starts low risk and then all of a sudden changes? Does that then mean that at that moment you're no longer low risk? So therefore you're somehow in violation because you're having your low risk labor just became a high risk labor in a moment.
She had a definition.
Yeah,
Yeah. And
Low risk means uncomplicated perinatal care provided to healthy patients during the childbirth cycle, including normal pregnancy, labor, childbirth. So I read that as if it's low risk in the beginning, that's it. You know, I don't think they're gonna make a decision 5 minutes in unless it's gonna be an emergency where they're gonna need transportation anyway.
go ahead.
sorry, I don't mean to be the witness, but in my experience and that of my friends who have done birth center births, you sign an agreement with the birth center and they have rules around process of having a relationship with a medical facility, transfers and things like that. And, you know, you have regular checkups. And so there are multiple points at which they would do a handoff and they're attached to different medical measures.
Right.
So they're constantly
Your
checking.
question was a little different though.
Yeah, my question is, we had in the bill, the original bill, we have low risk.
You have low risk on line 9, birth center means, yes.
And I'm wondering, and which I think that it starts out as that the way we have it is low risk deliveries.
Right.
So when you have a delivery, it starts as low risk. But the way that they have defined it and asked for further definition by including each individual piece, particularly it's the labor piece that I'm getting at, is what happens when all of a sudden that low risk, what you thought was going to be a low risk delivery, then the labor perhaps turns high risk. Do you then sweep them into why were you doing this anyways? Because it was high
I
risk.
don't think so. I mean, I think this is the reason that you have in the rulemaking, and I actually thank you to stakeholders who've given me some additional proposed language around the rulemaking for transfer. But if a low risk, what looks under reasonable medical judgment to be a low risk delivery suddenly turns into a high risk delivery, I think that's when that may trigger the transfer and transport protocols. But generally, there is not, if a reasonable provider under the circumstances would have thought it was a low-risk delivery, it doesn't, I mean, this is about licensure of a facility for one thing, but there wouldn't likely be discipline. This is where sort of enforcement discretion comes in. If it wasn't foreseeable that it was going to become a high-risk delivery when it began, there generally is not liability for someone who could not have foreseen what came. I mean, I'd look to others in the, who are, people who want to talk on the side, so I may have gotten wrong, but.
Lori Foster, ECN Airman, Vermont First Center Coalition. It does say on line 19 on the document we're looking at,
Page 7.
page 7,
Oh, page 7.
that in the rulemaking, the scope of services that may be provided at birth center, including risk factors that preclude a patient from receiving labor and delivery services at the birth center. So it does
That's number
specify that.
4 there.
I'm just
I think-
wondering
I mean, I
if
think
we
really
need
what-
to define what a low risk,
Low-risk delivery is.
that's in rulemaking.
So rulemaking is going to be around, right, around the types of, also hopeful reminder of what's in the rulemaking tool. I think it's up to you. I think where it has gotten confusing for me is that the definition you were provided for low risk is well beyond the scope of deliveries.
Yeah.
So are you looking to amend your definition of birth center so that the whole perinatal period needs to be low risk? Or is it really the concern that somebody will be giving birth and may need additional medical interventions beyond what's appropriate for a birth center? I think it was my understanding more that you were concerned about the low risk on the delivery piece, and that's why the language reads the way it does. But the definition you were brought for low risk is broader. And so if you want to have a definition of what a low risk delivery looks like, I'm happy to work with stakeholders to define that term, if that feels like an important term to define.
Does anyone have strong feelings about adding the OPR language?
I think it is that, well, I guess this is a question. Could it leave out any applicant who wanted to start a birth center that wasn't going to offer follow-up services or whatever? Who would it leave out if we added that language?
If you broadened it to say low risk pregnancy or low risk
Yeah,
perinatal.
perinatal. Because right now, if we're just talking about deliveries, and I think it's highly unlikely that anybody would just say, come on in, have your baby, go home 3 hours later. But
Look at their definition is uncomplicated perinatal care provided to healthy patients during the childbearing cycle, including normal pregnancy, labor, childbirth, and the postpartum period. I think you, to some extent, you may need to define some of those terms then as well. What is it? What is uncomplicated perinatal care? What is a normal pregnancy? What is a normal postpartum period? So it may be solving a problem you don't have with the language in the bill as it came to you.
I'm just trying to reset in my mind exactly what we're doing. So the only time we use low risk in deliveries in this bill, or low risk, is in the definition of what a birth center means.
Yes.
So we're not creating a definition, this committee is not creating a definition of what a low risk pregnancy is. We're just defining what a birth center is.
Right. And to Lori's point, Lori back there, Lori, it may make, to the extent you want to have ensure that this is really determined and defined what a low risk delivery is, you may want to make changes on page 6 in the rulemaking about the scope of services that may be provided at the birth center. You could say something beyond risk factors. You could say including, what a low risk delivery means, and or something, and risk factors that preclude it. I mean, you could have some of that fleshed out more in rulemaking if that seems important.
Lori Foster, I think that is, that will definitely be fleshed out in the rulemaking. So that is where, you know, what is low risk really gets defined. And it's as, you know, you heard from Catherine, it's rather extensive. That's not something that is typically put into statute or is helpful to put into statute, honestly, because I have been doing this for over 40 years and there are some changes that happen, you know, in terms of what is defined as, you know, high risk and what is not. So I think, you know, that the rulemaking is a place to do that. That's my opinion, but we, you know, what makes birth center safe is the risk assessment. So nobody's trying to like, you know, avoid or evade risk assessment. That's a primary part, you know, as we've heard from more than Catherine and myself, that's what we do to make it a safe environment.
Mari,
That's what I was gonna say too. I think I want to keep it the way it is. I'd be comfortable adding what you suggested, Jen. I agree that trying to create more broad or extensive definitions of what a low risk pregnancy or low risk, even broader perinatal period in statute is really problematic. As the issues of omission, if you you can't list everything and then you omit something. So I think rulemaking is a much better place for that, and for what we're hearing that we know that would happen anyway, but so it's fine to put it in statute.
Yeah, I mean, I don't know if you need to even put it into the rulemaking piece because you're talking about risk factors that preclude a patient from receiving labor and delivery. That's what it says, services.
Yeah.
Again, if you're looking to have the risk factors apply to more than just labor and delivery to the entire perinatal period, maybe you want to call that out. But I think what I've heard from you is more concern about whether there are risk factors that make it not appropriate to have the childbirth occur in the birth center, but maybe there are some prenatal and postpartum services that would still be appropriate, even if someone ultimately had to have their delivery in a different setting. Okay.
so are we in general agreement that we should not change?
Yes.
That we believe that in the rulemaking process, we've already put risk factors, they're going to consider what the risk factors are. Okay,
Okay.
In the
So-
rules.
in the rules,
Right.
which we have.
Right.
All right,
Okay, also from OPR, they had some concerns about the definitions of licensed maternity care provider and licensed provider. I will say some of this language came to me from the kind of stakeholder consensus with the health department, so I'm not particularly clear what is meant, what term is meant by what term is intended, or what the term is, how the term is intended to be used, the way it's used. So there may be room for some clarification there, but I think it would be helpful to get some input from others on that OPR testimony.
so their concern was, if I recall, that they wanted to spell out what those licensed providers were because it could capture.
I wanted to exclude epidurals and surgical services. Such as.
That was in the definition of yet, so that's a little bit different, but I'm also looking, I just pulled theirs up again. I hadn't written that one down, but yes, they did want to specifically exclude certain services in the definition of a birth center about what is not offered. And I know there was some refinement from the committee this morning about what you would want to carve out if you wanted to specifically say it shall not provide, although I'm not sure it makes sense to put that in the definition of a birth center, but maybe more in sort of the operation of a birth center.
That was sort of my thinking. Is there another place that would make more sense to exclude?
I mean, we could add it in the definition in the same place where it says it does not include a facility that is a hospital, is part of a hospital, is owned by a hospital. The second. So the term does not include a facility that is a hospital, is part of a hospital, or is owned by a hospital, a facility that is an ambulatory surgical center. We could say a facility that performs cesarean sections, or, I mean, the rest of them are sort of location-based as opposed to service-based. But we don't really, the rest of it is kind of all about how you get a license. But I think maybe in the license and prohibitions in the next section, it could go with the, can't operate a birth center without a license. There's the licensed maternity care provider ownership piece that was causing some confusion this morning. I think potentially we could put it in that piece on the prohibitions, and the rest of it is really about application process, license requirements, vacation of a license, appeal, inspections, records, rules, no effect on scope of services. Yeah, I mean, we could just put it in at the end, we could just put a standalone section that has that prohibition. If the committee feels like that's important, or if you feel like it fits within providing low-risk deliveries. I mean, if it's already sort of inherent in low-risk deliveries.
Does anybody have any deep thoughts about this?
I
I see it.
wonder,
Sorry.
is it a big deal to use their definition? Is it a big deal?
Are you back to the OPR?
The OPR language for the definition to exclude.
Because they use the term
Epidurals.
low-risk deliveries in it.
Right, so I think there was consensus about not using their definition of low risk because it was broader than deliveries, but then they also suggested specifically excluding epidurals and surgical services. And I know there was some concern this morning about
Surgical.
surgical services potentially being an overly broad term.
They've included it in the definition of a birth center, but Jen is thinking if we want to do that, it should not be.
It seems more like it's regulating what a birth center is doing, which doesn't seem like it belongs in the definition of a birth center. It feels more like it belongs in kind of the regulation of a birth center. So
That's my sense of
that's
it.
part of it. It's licensed, but it's not.
True.
Those-
True regulations.
50 pages of them, I didn't read it. Yeah. Are you finished or are you so, unless Mari wanted to?
No, I'm okay with taking out that piece of it, the epidurals and all that. I think what they're trying to say is, we don't want major surgery being done there.
Right. And I think for some of the providers, that would not be within their scope of practice. But I think if that was I don't know that there's anything other than the low risk delivery. There's nothing that specifically says they can't offer or perform a C-section.
What if we did this, Jen? What if we said, expected low-risk delivery, and then in the rules, they can deal with that?
I think we've moved on from low risk.
Oh, yeah.
Yeah. I think we're talking about epidurals and cesarean sections now. So they're requesting that, or their
They are.
suggestion was to put it into the definition.
Yeah.
And
Why don't you put it in rules then?
Jen's suggesting that we maybe put it in rules. I'm just trying to get a general idea of whether or not, before we decide where it should go, if it should go at all. So Mari, and then Lori.
There's
I will.
OPR's testimony up, just so that we can all make sure we're looking at the same thing.
Mari.
I don't think it's necessary. I don't think we need to have it in there. if the committee decides that we do want it in there, I think it should go in where Jen thinks it should go. I'm concerned about the suturing issue. And also, if, let's say, an OBGYN was, like a surgeon was working in a freestanding birth center, it would be within their scope of practice to perform cesarean, but that's not what birthing centers are designed for. You need anesthesiology to do the nerve block, the spinal block. You'd need all sorts of medications that are not part of what of a birth center's formulary. It just seems pretty far out there as a possibility that I just think we should not include it.
Let me, let Lori really briefly.
Yeah, it's very, very simple. I mean, I don't think anybody, if the committee feels the need to say no epidurals and C-sections, no one's gonna object to that because no one would ever have an intention of that. You know, I think our only concern would be leaving in the vague language of the, surgical services, because we have to be able to suture lacerations, and that, that's very important. So that's just.
Surgical? Anything where you break the skin, it can be considered surgical.
The scope of practice goes, it's not in my scope of practice to
Okay.
do sutures.
Leslie?
So I'm sorry to miss part of the conversation, but I'm thinking about someone not in our committee who hasn't sat through all of this, meaning our colleagues reading this. And I would prefer that we say a birth center does not offer epidurals or cesarean delivery, period. And then anyone who might be worried about that aspect would be very clear right up front. The rest of it would then be decided by rule. There's nobody doing a cesarean section in a birth center, just as you said. But I would like to acknowledge up front that that's not happening.
Is everybody in agreement that we can put it in where Jen thinks it's most
Yeah, I'm just
appropriate?
concerned if it's in the definition, then it seems like if it does offer epidurals, then it doesn't fall within the scope of this chapter, and that's not your intent.
But
And take out surgical services.
Okay, yeah.
only cesarean.
Epidurals and
Cesarean.
cesarean, if we say cesarean delivery, cesarean, they say
Delivery.
cesarean deliveries, that,
Or you could say surgical delivery, would that be?
No.
No, cesarean delivery.
Cesarean delivery.
Yeah.
So now we're going the other way. I think we should be consistent here. If we're gonna leave medical procedures to the rulemaking and a specification in the definition to rulemaking processes, I think we should be consistent in how we do that. And I know we want clarity for our colleagues, et cetera, but I think we also want to be sure that these places are safe and that they reflect the intent of the licensed professionals who are standing them up. That's my sense of it. And
so I'm not sure, so are you saying not to speak to which services and let the scope of service be determined in rulemaking?
yes, and I agree with Mari that the surgical procedures should come out. And I agree with the nurse midwife in the corner who noted that they actually do need to suture lesions.
We're done with surgical procedure. That's off the
Right,
table.
I don't think-
So let's not fixate
I
on
think
it.
the question is, do you want a prohibition in the statute on a birth center or a provider, at a birth center, performing an epidural or cesarean delivery? Or do you want to remain silent on what specific services are and are not allowed and put that, kind of delegate that to the rulemaking?
Leslie?
About the poor bill reporter who could get interrogated saying, will this include, a cesarean delivery? And to punt it and say that'll be determined in rulemaking doesn't feel that comfortable to me. I feel like that there are clear boundaries, that we are not doing epidurals, we are not doing cesarean deliveries, and the rest of it will be decided in rulemaking.
I am in agreement with Leslie and it does not hurt to put it in. It
That
doesn't
will
hurt.
inform, yep, that will inform what can happen in rulemaking, so that will be sort of off the table. They won't, I mean, they may put in conforming language to echo it, but it can't go against what you've put in the statute.
I just want to make sure that it goes in the place where Jen thinks it should be.
Yep.
So you only want epidurals and cesarean sections. You'd want to get rid of the surgical.
Right.
Yeah,
Yeah.
so take out surgical.
I think that's wonderful.
Make a blood draw is considered a surgical procedure. Yeah.
No,
Yes, it is.
not in terms of scope of practice, maybe in terms of coding.
It's in the surgical section of the coding book. Anytime you break the skin.
Wow. Thank you, Jen.
Thank you.
Thank you.
Okay. Back to the bill.
Maybe actually that they don't do vasectomies or tubal ligations.
No.
No, let's,
Wow.
Nope.
okay, all right. We're still on page one. So
So OPR had some, I think,
Need one?
valid concerns about some of the language around certified nurse midwife and APRN. I do think it makes sense to do sort of more of a hybrid version. So in the bill, there's on page one. In the bill that we're looking at, certified nurse midwife is just pointing to the fact that they are an APRN without specifying what, that they're one of the, only one type. And so in OPR suggested language, I think they say means an advanced practice registered nurse who has additional training. I think it would make sense to say, means the professional license in accordance with 26 VSA chapter 28, subchapter 2, who has the advanced training. So that we're still pointing to the APRN licensure statute, but then we're putting in that additional more limited focus for a certified or specialized focus for a certified nurse midwife. Does that make sense and work? Okay.
Makes sense. Is everybody understand and in agreement with that? Yes, so we'll ask Jen to make that change.
Great.
That's the way.
Okay. Just trying to hop back and forth between their language and. Get down. All right, that is certified nurse midwife. Yes, their confusion around licensed maternity care provider. Do you want me to? They wanted to consolidate. I don't know. I haven't had a chance to think about whether that makes sense.
Since we're still on page one of Bill. In the definitions, we're still on the definitions. Number 3 is change of ownership.
Yes.
So where does change of ownership reference in the bill?
Change of ownership comes up, I have to remember, but I think in the. Looking, I know it does come up and it's not in a CON context.
The application fee.
Is that what it is? Okay. Yes.
Yeah,
Yep.
okay, so it's just the application fee.
Yep.
Okay, I wanted to,
No, it's a good question.
wondering what, if we even needed that in there. But Tupper?
Just something to clarify. If we leave in epidurals and, whatever the other last thing was,
It's a
does that, excuse me, does that mean that, opioid pain medication won't be necessary? Because that was one of the things they talked about too.
That's different from an epidural. I don't know how they relate, but it doesn't specifically. I'd have to defer to other people. I don't know how to.
It doesn't apply.
It's not part of.
It's not.
That's what I'm sure. Does that
Doesn't apply.
erase their concern about that?
Yeah, because you're not doing any surgery.
Yeah.
I mean-
Well, that's what I figured.
Maybe having a episiotomy repair, but no one would give you an opiate for that.
These women are tough.
Well, the
They are.
The opiate, that was their concern around pharmacy statutes and the regulation of the practice of pharmacy.
I did see, like storage and.
Yeah. And they didn't want to be in the position of having to license and turn a section of a birthing center into a pharmacy like they do in hospitals and
The last line there, though, the OPR hopes to be included in any relevant VDH, so we could put that.
okay.
All right, so we don't need anything specific there. It seemed like it was just, they were flagging it as a possible concern depending on how things rolled out and wanted to be included in rulemaking discussions.
Okay. But we'll leave that to rulemaking. All right.
What page are we on now? Two?
Mhm.
Of the OPR memo or the bill? I think we're on page 2 of
We're
the
on page
bill.
2, and we're still, I keep coming back to this licensed maternity care provider and licensed provider issue. They're not clear on the intention behind the definitions. I'm not entirely either, so I don't know how you want to handle this.
They're not clear. And we're not clear.
I feel like the first one is potentially an easy fix with licensed maternity care provider. Their interpretation is that it's unclear whether only licensed maternity care providers can independently own and operate birth centers, or if others can. I was under the assumption that someone does not have to be a licensed maternity care provider to open a birth center.
And they made that clear
Yes,
this morning.
because Topper's
Because I
an
asked
open
them.
one.
Yeah, so can we come up with some language that makes it clear that someone doesn't have to be a licensed maternity?
Yes, I think you could say, or any other person or something like that after.
Or an individual,
Entity?
because it's only used
One
once.
person is the broader language in Title I. I mean, I think the point of having that language there was to address any question about whether or any suggestion that a licensed maternity care provider, like a licensed midwife, could not independently own or operate. And so this language is saying they can, but it doesn't, but it's not exclusive.
Yeah,
Yeah,
Um,
okay.
yeah, I'm
So-
unclear with that too. You're right. The language just allows a maternity care provider. It doesn't exclude anybody else from it.
I think the lady that testified this morning must rent that space. Remember, I asked her about how big her building was, and she said she doesn't own the whole building.
Yes, that's right. She's in the
So-
industrial park.
She, these people, the birth center does not own that building there, so as long as they follow all the regulations and rules.
So we could say licensed maternity care provider or other individual.
Well, I would say, or any other person, because it could, right, because it could be, could be a LLC, it could be, I don't know how that would
Right.
be an organizational group.
But that's already in there. There's nothing prohibiting anybody from owning one.
Correct.
All we're doing is we're saying it may be owned by,
Which would still need to be licensed by VDH and staffed by licensed people.
It could be owned by a private equity corporation.
And anybody.
Sorry, that just came to mind.
So maybe we just say, or any other person, who meets the requirements of this chapter or something like that.
yeah.
Because that also means we don't really have to get into that. Oh, wait, but now we put hospitals back into it, because no. Okay. No, get further, that should be phrased differently. Great.
Thank you.
I'm only seeing that in the definition. Maternity care provider.
License prohibitions. Page 2. All right. Moving on.
It can't show up. When I look something up and it doesn't show up again, doesn't it say licensed maternity care providers defined on line 5 and then also
Line
I
18.
need, all right, yes, but it didn't, when I did a search on the page, it only showed that one.
Line 2.
So it may be, there may be a line break there or something. So there may be 2 spaces in it or something funky like that that's making it not show.
I feel like if on line 19, we just added after that maternity
Yes.
care provider.
Or any other person who meets the requirements of this chapter. That's what I put in. But I was
It's basically anybody but a hospital, right?
well, or who, they have to agree to, they have to meet all the requirements.
Supervisor.
So a licensed maternity care provider is a type of provider, it's a licensed provider who, so that's a narrower subset of the larger definition 7 licensed provider. I do think OPR's comment about APRNs and certified nurse midwives is a good point, although I think there are reasons that both are listed. It would be strange to mention licensed midwives, but not certified nurse midwives here, but then it's not meant to be exclusive of other types of APRNs. I think that's but maybe it should just say advanced practice registered nurses, including certified nurse midwives, or something so that it's clear it is that is one type, but it's not exclusive. That's right. What else? I'm just trying to work my way through those comments. I think we're okay.
Okay.
With those 2 different terms. As long as we're cleaning them up a little bit, but so what do we have next? Tell you what I'm next in my notes. Doesn't happen for a while.
So we don't have, it looks like we're on to the fees section. Oh, yeah.
There was something about striking doctor nursing practice.
Oh, thank you. Yes, I think that language came from the stakeholders, so I don't know if there's some. Well, I think that language came from the language I was giving. I think the concern came from up here.
Okay.
Does anybody have a problem with taking out doctors of nursing practice as an example of a type of licensed provider?
Oh.
Because I agree that's an educational
Yeah.
attainment. It's not a
Not a license.
licensed provider. Okay, thank you. Okay. Good catch.
Thank you, buddy.
There's no INT in here.
We so philosophical today.
Me and telling bad jokes and.
Yeah.
All right, so the next, is there something about fees? I didn't have anything about.
Yeah, I have enough. I just wondered if anyone had anything about fees. Okay.
Yeah. Well, Blue Cross Blue Shield had something, I believe.
That's about the facility fees when we get to their section.
Okay.
Yep,
All right.
but I think the chair is talking about application fees.
Application fees.
Yeah, they wanted them out.
$250.
But not that, but they didn't want the application fees out, so we're still good, still going through. I'll put the language back up so we can all be on page 3 together. And then page 4. And you heard from the inspectors. Today you heard from Dale about their inspection process. So the next place I have notes of anything is when we get to rules, unless anybody has something else. And a couple of things here. One is we talked about whether you wanted to add something in number 4 about defining low risk, or if that you feel like risk factors is sufficient to tie into the low risk on the first page.
I personally feel that saying risk factors in rulemaking, they will decide what is low risk.
That preclude a patient from receiving labor and delivery.
Is everybody okay with that? Okay.
Okay, and then the other piece that has come up is around the requirement for written practice guidelines and policies that include procedures for transferring a patient to a hospital, circumstances warrant, and this afternoon I received but have not read language that it sounds like BMS and the birth center advocates have come to an agreement. I don't know. Gail, if you're okay if I just put that up?
Is everybody okay with just putting that up?
Can't wait to see
I'll
it.
put it on the screen, okay. Here it is. Oh, Gail, it's gonna put your, I'm gonna copy and paste it into a doc because otherwise it's gonna put your email address. Very small. Make it bigger. Okay, here is their proposed language. So the language in the bill says, and this one starts with a requirement for written practice guidelines and policies. And then their language goes on to say, which shall be provided to any consulting specialist and hospital receiving transfer upon request. Guidelines and policies include procedures for transferring a patient to a hospital if circumstances warrant. So that's from the bill language. And then new is collaboration with other agencies, institutions, or individuals for services to clients, including laboratory and diagnostic services, childbirth and parent education support services, obstetric consultation services, pediatric consultation services, obstetric and newborn acute care in licensed hospitals, and home health services. And a mechanism for providing guidelines and policies include a mechanism for providing the health record of the mother and or newborn, subject to privacy laws and patient consent, to receiving provider and or facility on referral or transfer to other levels of care. I'd want to modify it a little bit.
I'm sorry, what is this replacing?
So this would go in on page 7 at the end of the rules section, number 11. Yeah.
And this was the hospital's concern that they wanted.
I think this was between VMS, is the
Collaborative.
hospitals are on board, okay. VMS, the hospitals, and the Birth Center Coalition.
Mari?
I like that it doesn't, I think I like that it doesn't specify what the mechanism is. Did you have a conversation about whether it would be electronic or telephonic or handing copies of a chart to somebody?
Yes, go ahead. I'm sorry, Jessica. Didn't see your hand.
Well, again, this is in the rulemaking section, so we figured any more detail could be, if needed, to be spelled out in rulemaking. I think we also all felt comfortable with this language because it is largely taken from Birth Center accreditation standards already. So it's already a requirement. It would already likely be happening, but I think at least the medical community felt better seeing it in writing in the language, to just know it would be happening, but that's where this language came from.
So I'm trying to imagine how the same thing happens for non-birth related transports. Yes, electronic health records have helped if it's a transfer between hospitals that use the same electronic health record system. But if EMS is bringing patient from home in acute heart failure, and then the hospital doesn't have access to any documentation, what's the process in that situation?
Because it isn't coming
Go ahead,
from
Deb.
home, though, right? This is coming from the birth center. It's coming from the birth center. So how do they kind of hand off the health record, I think, from, yes, how does the health record go with the patient?
I guess I'm just saying I'm okay with this. I'm just saying there are, I think, many instances when the hospital receives patients where they don't get a health record of a patient beforehand.
Or even the doctor's office sometimes doesn't. Leslie and then Alan. Oh, okay. Yeah, I see you, Lori. Just get the committee members.
This seems really complex to me to actually operationalize. I'm not sure why we would need to communicate the written practice guidelines and policies, which really will have nothing to do with the individual patient being transferred. Is my interpretation of this, but maybe I'm not getting it. I absolutely think the records need to go with the patient for obvious reasons, but that's not what that says unless I'm missing it. Because this is practice guidelines and policies.
This is in the rulemaking now.
Right, so the rulemaking, to go back to the lead-in language, the rulemaking will be based on national birth center standards published by the American Association of Birth Centers and shall at a minimum include provisions regarding, and then 11 is a requirement for written practice guidelines and policies.
But that's after receiving a transfer. That's what I'm confused about.
We're just asking them in rulemaking to.
I think the question is, what is this shall be provided to consulting specialist in hospital receiving transfer? And so is the question, shouldn't they already have these before we're ever talking about a patient showing up
Yeah,
at the hospital?
we're saying that rules need to be made around. I'm not getting it, so I need help.
So I think and maybe it's the receiving transfer part that is, yes, that is confusing.
Mhm.
So I think the point is that these would be, I'm not sure when the consulting specialist would happen, but this would be, for example, provided to a hospital that would potentially receive a transferred patient so that it would be on board with whatever these practice guidelines and policies are before ever receiving a patient.
Which seems different, if I may, than what we heard this morning from our tour, and I don't recall her name, but that you get a transfer and you call the transfer, line, and you make a transfer with whatever problem is coming up without written practice guidelines and policies. So I'm trying to.
I think the written practice guidelines is how the birth center is going to handle doing a transfer.
Internal, get it?
It's not an agreement
Yeah.
beforehand. They're not,
Right.
that's the difference.
But
That's her 750-page thing that she.
Which she has internally, but that's not what's going to the hospital.
Hold on, gotta plug in.
Can we, let's let
You're fine.
Lori, I think we're misunderstanding sort of what we're trying to do here. Lori, if you wanna.
Well, I actually think
Speak to
Representative
this.
Coleman's point is well taken, because I think we've kind of put this together in a way that is confusing. Because the number 11, what in general, we at the stakeholders felt like the sort of procedure for transferring would be in the rules. Other parties felt that it needed to be in the statute. So these things are things we would do no matter what, so we were okay with it in the statute. However, I think number 11 refers to more than transfers, and I think that's the confusing part. So I think we have to say a requirement for written practice guidelines and policies, period, okay? And then, or, and then specify the things that have to happen for the transfer. Because you know what I mean, like, I think this is a little confusing because there's policies and guidelines for transfer and collaboration with hospitals and EMS. That's gonna be part of the policies. It's not gonna be the only part of the policy. So I think that's what you were getting at, right? And I think that's a good point. I think it just needs to be refined a little bit.
Yeah, so it seems like maybe it needs to have two separate, maybe there needs to be an 11 and a 12, and 11 is about having a written practice guidelines and policies that include procedures for transferring a patient and perhaps other requirements for other written practice guidelines and policies that address some of this other stuff.
I think you mentioned that this is not how you would have written it. Why don't we look at it? Why don't,
Well, I think I need to understand a little bit more from the stakeholders, which I can do offline, but what they were
and then bring it.
going
back
for
to
and
us.
bring it back.
Is that all right?
Yeah, can I just,
Yes.
so, yes, and because what I'm seeing in there that a woman is hemorrhaging and you're needing to do an emergent transfer, and oh, by the way, the hospital's requesting the 740-page document, and how are we gonna get that to them? So yes, please separate those
Yeah.
out.
Okay, yeah, and I think it needs to be clear what upon request is modifying
Yeah, yeah,
and when these would
Yeah,
be
and to
provided. and-
Leslie's point about what the midwife was saying earlier, she was talking about an agreed upon agreement with the hospital that the hospital has I don't have it's like a collaborative practice.
Yeah,
agreement or
and I
something.
think we
That's-
had that,
hear that.
I think we
That's
had
not-
that for the
that's what
licensed
it's-
midwives in,
That's what it sounded like you were referring to when all this is talking about is policy. Not about any special agreement with the hospital, it's just talking about policy.
Mhm.
And Kate was referring to something else.
so I don't know if it's helpful. I mean, there is an existing in the midwives, licensed midwives statute, there's a,
That's his from.
I know,
Yeah.
I'm just thinking of it as a model.
Yeah.
There has to be a written plan for consultation with, physicians and other healthcare providers for emergency transport of an infant to a newborn nursery or neonatal intensive care nursery. I don't know, we have to be this specific, but and transport to an appropriate obstetrical department. It has to be submitted to the director of OPR and reviewed. I mean, I don't know that it needs to be this specific when we're talking about birth centers, but this kind of concept does exist of having, that was important when the licensure piece was being developed for the licensed midwives, that there be kind of a plan worked out ahead of time for what happens if the patient needs to go somewhere else.
Correct me if I'm wrong, I think we already agreed, Jen, that you could work with people and come back with something.
Yes.
Thank you.
But
Is it something that can wait till tomorrow when Jen comes back with us?
well, no, because I think it might inform the language, because what I heard, and maybe I misheard, was that the midwife we met this morning does not actually have a formal agreement with anybody. And then they call 911, if God forbid, but so I'm not sure that we wanna go back to the home birth language necessarily.
Yeah, no, I was just trying to give that as an
Okay.
example of something that exists in another context, maybe not helpful. That's fine. No, we'll work off of this language and try to sort of figure out what is intended and then bring it back to you as language.
Thank you.
So this is really sort of transfer is one and
Come
collaboration.
back to it tomorrow.
I just make one version.
Yes, very short.
I think the main thing is it has to be written guidelines, not an agreement. The agreement part would definitely be.
Okay. Then the next thing I have is the health insurance coverage. That,
Section 2. There's.
Oh, are you on
all the way-
OPR or are you-
all the way up.
Okay, yeah, so we are now on
Page
page
eight.
8.
yeah, let's put it back up.
Concern.
So this is the piece that Blue Cross had. A couple things they wanted to strike the settings, some of which are in existing law, and they wanted to strike the facility fees. I will say, I did look at the statutes while they were, the witness said she's sure there's other places that require coverage of prenatal, maternity, postpartum, and newborn services. I think that require newborn services. I'm not sure the rest of it is affirmatively required anywhere. Now, I think it's part of our essential health benefit, essential benefit package. And so it is covered because it's part of that essential health benefits. But it is not specifically required elsewhere in statute.
So Blue Cross Blue Shield had requested that we just get rid of including birth center facility fees.
That was one of the things they wanted, is getting rid of including birth center facility fees. I don't know who pays birth center facility fee. I mean, I think that was the chair's question, is
I think that
who would pay that?
the individual.
Yeah, I think the individual does because,
Oh, New Hampshire.
Well,
As the insurance company would.
right,
well, I had asked though about Medicaid.
and that'd be under the same thing, right?
Medicaid's a different section.
Medicaid is
It
different.
is, but if you don't pay for a facility, if you get rid of facility fees, is that all
I mean, I think
facility
it
fees?
leaves it open about who pays the facility fees if you don't specify it. I think
Yep.
with hospital services, I believe the facility fee that is separate from the professional fee is still covered, at least in part, by insurance.
I heard that too.
And I thought I heard Blue Cross paid the facility fee.
If they're contracted with them, yeah.
Yeah, so I think we should leave it.
Well, they indicated that they pay facility fees, but that it's not in statute that they have to because they pay for the care. Because in the essential plan, they're paying for the care and they just didn't want contract. Because they were thinking that you must now have a contractual relationship with a facility, with a birth center. And we don't ever say you have to have a contract with someone.
Well,
Doesn't
there's
mean
a
that-
requirement that they cover these services provided at a birth center.
But it
I
doesn't,
think that requires them, does not require
It's
no, I
them
mean,
to be under,
they're required to pay for primary care as well, but they're not required to pay a certain primary care provider who is not contracted with them. It's a non-contracted provider. I mean, we don't have
then
the,
wouldn't it be an in-network, out-of-network
that,
payment issue?
I think that's what they're saying though, is that this is more of a contractual issue that by naming birth centers, we are,
Talk about facility fees.
we
A lot
are,
about facility fees generally,
we
but
are requiring them to have a contract with all birthing centers in case somebody had their child at a birthing center. We're now requiring that regardless of any contractual relationship, that they have to pay for it. That was their argument on
Yeah,
this.
didn't want to mix contract with.
I heard that, I just didn't
They said
entirely follow it, so I'm trying to understand,
get rid of.
trying to understand what that,
Who said that, Woody?
Blue Cross Blue
I
Shield.
thought they said get rid of contract language.
Yes, yes.
Yeah, they don't want to
That's-
mix it with the coverage. They could-
We are expecting something in writing, right?
and I guess I'm looking to see if we
Lori, did you have a really quick comment?
Yeah, I mean, I just want to say that I think it's very important to keep it in there because they could say, oh, we'll pay the provider fee, but not the birth center fee. That's, you know, in the case of, the New Hampshire birth centers, that's what Vermont does. Vermont Medicaid pays the provider fee, not the birth center fee, because we have birth centers. But the New Hampshire insurance companies pay both. Blue Cross Blue Shield is not gonna say, oh, we'll pay the doctor who delivers your baby in the hospital, but we're not gonna pay any of those hospital fees. Right? And they themselves gave us that sheet about the costs of the fees, you know, where the fees for a birth center are a fraction of what they are at the hospital.
They are, but that's Vermont Medicaid, and currently Vermont Medicaid cannot pay a birth center in New Hampshire because we do not have coverage for birth centers in our state plan. And yet we've added that into this bill under section 4. So that's the only reason why Vermont Medicaid can't cover, but insurance companies do. Commercial insurance pay, Blue Cross Blue Shield told us how they pay, they have contract, they contract with
Right.
two. But their argument around removing this language is that this is a contractual thing, that we're telling them that they must pay for facility fees at all birth centers. But they only, if there are 4 and they only have contracts with 2 of them, there are 2 out of network. And so we're not saying that they don't have to pay for birth centers. What we're saying is they don't have to pay wherever that birth takes place, which might be a non-contractual place. And we can't compel them to pay non-contractual places. Or am I totally misinterpreting what Blue Cross was saying?
Now I'm confused.
Yeah, this went like through. Look, we could read just because you have coverage for a service doesn't mean you have to pay for that service if you don't have a contract with the provider that's providing that service. And I think that was their argument, is that if we put this in here, we are now forcing them to pay for facility fees at facilities where they might not have a contractual relationship.
Right, so I mean, so one option would be to say including birth center facility fees at in-network birth centers. Right, birth centers participating in the plans network.
But
It only will.
Sure.
how would that, it just says in it, the woman that was, on there this morning, how would that affect her? They're not in the,
I was not here for
well,
testimony.
they're in New Hampshire. So they probably, Blue Cross Blue Shield said that they had an arrangement with that,
They have a contract.
yeah, with that particular one. I think it was 2 of them, though, wasn't it? 2
They have a contract with 2, and they pay those too.
Yeah,
It was Vermont Medicaid that doesn't.
Yeah.
But it's not that Vermont Medicaid doesn't have an arrangement with them, it's that we in our state plan do not cover birth centers because we don't have any birth centers. Which is why we have section 4, which allows Vermont Medicaid to seek a waiver or coverage from CMS to cover birth centers. So that's why she's not getting paid from Vermont Medicaid. We're conflating Medicaid with commercial insurance.
That actually was helpful for you to outline it like that. Or whatever you did to explain it, that was helpful.
so the argument that some people have is, payment piece. Period. They're not paying if it's not in there.
What I was saying is that if we don't put it in there, they could say, oh, we'll pay the provider, go track it. They could say that.
Yeah.
You know, so I think that the suggestion that was made about putting in, I'm sorry, how did you say it?
Yeah.
You know.
Participating in the health plans network or health insurance network.
Do we have currently So in our state plan, it's a requirement that you pay for,
Say state plan, are you talking Medicaid state plan?
our essential benefits, essential coverage. That you have to pay for maternity care, prenatal care.
I am assuming so because it's, I mean, those are both part of the ACA's essential health benefits and part of the plan that was chosen as the state's benchmark plan. So
So I guess what I'm asking is, in that, is there something that says that all fees, including facility and providers, that you have to have coverage for those?
I don't know.
Okay,
I don't know that I don't know the extent to which it addresses facility fees. I think the issue, as I understand it, and that I think you've heard, is a concern if you do not specify that they pay the facility fee, that they will pay only the professional fee and leave the facility fee for the patient to pay out of pocket. I don't know if that's a realistic concern, but there's certainly been a lot of talk in the last many years about facility fees and patients getting surprised by facility fees.
It sounds to me like, I personally want health equity. That's something we've committed ourselves to, but also equity for providers. And to me, that includes partners across the system, partners in Vermonters Wellness. So I don't think it sounds fair that we allow hospitals to charge a facility fee and not birth centers. So birth centers being a fraction of the cost, like $30,000 to $3,000 for a birth. I don't think the surprise is going to be as devastating for someone giving birth at a birth center. I think the language Jen offered, saying adding in network, sounds good. And yeah, I think in the essence of thinking toward providing equity to these healthcare providers, these licensed healthcare providers, that we should allow them to collect a facility fee and they would still be able to negotiate a contract for that.
Leslie?
I think I need some help understanding what limitations get put on by say in-network. Because that would have to do with the individual's plan that they have with their insurer, in this case, Blue Cross. And what if that in-network, out-of-network thing is not addressed in their, I'm just confused about that language and how it might apply.
The in-network, out-of-network?
Yeah.
I mean, I think all plans address what they pay in-network and out-of-network.
So then Blue Cross would need to include birthing centers as an in-network benefit?
Well, they would need to, I mean, if you are requiring as a insurance mandate that they provide coverage for prenatal, maternity, postpartum, newborn services provided at a birth center, then
Now
I think they're going to need to have at least one birth center that's in network if there is one.
And at this point, there isn't.
right, there is in New Hampshire.
Yeah, but they're probably out of the net.
Right, this is a birth center licensed under Vermont law.
So that would be automatic, that would be considered in network by that process. That sort of,
Well, I mean, Blue Cross contracting with a birth center to be a participating provider in their network.
that would make it a
a network.
Thank you.
Yes, and I may not be describing it right, how it works or
get the
using the
language.
language right.
I don't want to exclude
Um,
anyone because we don't have the correct, well, I mean, you know,
Right.
I don't know.
What impact would that have on the individual?
What impact would what have on the individual?
Saying that in network, you have to provide it.
Well, I think it would be specifying that the birth center facility fees would have to be
in Vermont.
covered for in-network. I think I'm getting out of my depth here on what and how insurers contract with providers. I don't know enough about.
It says insurance would have to pay part of this facility fee.
Yeah, I get all of that. But what I'm concerned about is the individual. We already know that in Blue Cross Blue Shield is paying or paid for 8 birthing center births, the facility fee and the 2 fees. Now, that individual, if they want to have their child in that New Hampshire birthing center that they went to before, what we're saying now, that in-network piece, how is that going to affect that individual? Are they going to be able to go to New Hampshire and have this taken care of? Or are they going to have to make sure that that birthing center in New Hampshire, or wherever they go, is in the network? That's what I'm worried about.
So right now, Blue Cross is contracting with them. Sounds like the provider, the birth center in New Hampshire is in their network because Blue Cross has chosen to have that provider in their network. So if they continued to contract with that provider and we had language about in-network, it would be in-network. Although this language in the bill we're looking at is specific to requiring coverage at a birth center licensed in
In
Vermont.
Vermont.
But it doesn't prohibit them from providing coverage like they do now outside of Vermont. But I think you'll want to hear from the insurer. I don't know enough about how they pay for things or how they decide, or whether the language, if we say including birth center facility fees, it means they have to pay 100% of the facility fees, and that's different from what they pay to others. So I don't want to tell you it means something and have that not be accurate.
Alan,
Do we force Blue Cross Blue Shield to pay a fee?
well, this language is forcing them to
I
pay.
know, that's what I'm saying, can we?
Force them to pay taxes.
It requires it to be covered as part of the benefit. So yes, I mean, it's a coverage requirement.
Can I kind of like try to level set and give a really like simple example that doesn't have anything to do with birth centers?
Please.
Let's say you have Blue Cross Blue Shield of Vermont as your insurance company. And you have essential benefit in your coverage is that you have primary care. Has to cover primary care. So you are choosing between 2 practices, Essex Family Health and Williston Family Health. Blue Cross Blue Shield has a contract with Williston Family Health as a participating provider. But Essex Family Health has said, we don't want to have anything to do with Blue Cross Blue Shield. We're not going to do a contract with them. We're not going to become Blue Cross providers. What we're saying in this language is that Blue Cross Blue Shield has to pay both Essex and Williston Family Health, even though one of them doesn't have a contract with them. We're basically forcing, with the language that we have in here, to require that Blue Cross has to pay facility fees at a birth center, regardless of whether or not they have any kind of contractual relationship with that birth center.
So what is the facility fee? So could they say it's $3,000
They could.
and they're forced to pay it?
Like a room fee.
Well, if you have a contract with Blue Cross, you
No.
would say, we'd like to become a contracted provider, and you have a negotiation about how much are we going to pay for your facility fee. And when you come to an agreement, you now have a contract, and Blue Cross pays you for that facility fee because you have a contract with them.
Can I comment on the
Yes.
process? And sometimes you don't even have a negotiation. Like I don't negotiate with them. They say, this is the most we'll pay you. And I agree with it or not.
That's what I'm getting at.
Yeah, yeah.
You know, we can force them all we want.
But then you don't contract with them.
Yeah. If you don't like how much they pay, you say, no, I only take out of pocket. And they pay more than Medicaid usually.
Okay.
No, Cigna does not pay more than Medicaid for the record.
Facility fee paid for.
Yes. Yes.
I think we term it
Yeah.
the way Jen has said, that if we can somehow add in some language about in-network or contracted or the language we have now is telling them that they must contract with a birth center. They don't have to contract with anyone they don't want to.
And then can we hear from Blue Cross? Just to learn.
Well, we did today, and in fact, I think Sarah actually said to us, what if we want a contract with that birth center and the birth center says, we don't want to have a contract with you.
That's true.
We can't force them to have contracts. It's two individual parties that we have zero control over. We don't get to tell them who they're going to
That's true.
contract
So they're
with.
okay with this change.
It's like unconstitutional.
Blue Cross
right?
wanted the whole thing taken out.
Lovely.
So do I remember the representative from Blue Cross saying that it was covered in other parts of the law? Did she, you weren't here?
No,
No,
the provider.
I have this echo in my head that she
Did
felt
she
it was
provide us with written
not yet.
testimony yet? Who was it?
Sarah.
Teach out.
For Sarah.
Recall that she said that she was going to write up her testimony.
Mhm. Right, they wanted to strike the fees in the settings. Was what she wanted.
Topper?
That's right, Jen. The other thing that she said was that the reason they were paying the fees in New Hampshire was because their patient went there. They did not have, at least my understanding was, they did not have a contract with either one of those places. But their patient wanted to go there and that. And that's why they don't want to have a contract. They don't want to write a contract.
And it may be helpful to get DFR's take on this as well.
Let's do that. Let's ask DFR if they can.
Just looking at some of the language that we have in S30, just because everything's all in one place. And, we do talk about health insurance plans may require services be provided by a provider under contract. But, in some cases, it does not relieve a plan from complying with applicable network adequacy requirements adopted by the commissioner. So, if they have network adequacy requirements for birth centers, I don't know if that would apply or not, but there may not be a practical choice about whether an insurer contracts with the one or two we have.
Yes, it will need to. This is not
Nice
part of.
try.
No, I mean, this will go to Ways and Means because of the licensing fee, the application fee. But no, these types of fees, these are between insurances and facilities. These fees have nothing to do with affecting the revenue of the state.
But they're gonna know the rules around.
I feel like it's
Or
not
no.
their thing.
No, insurance is not, I know that.
Yeah, let's
You're
move on.
This is kind of torturous.
Let's go back and I will go back and I will look at,
It's so hot in here.
Sarah Teachout's testimony.
Maybe I'm just.
We'll see if we can get better clarification of why we're doing what we're doing and then, or why we're doing what we're not doing. And we'll move on and we'll come back to it tomorrow.
There's no reason to rush this later.
I'm sure she's watching that.
I think the last. Okay. So the last thing, if I recall, we need to talk about is the certificate of need.
Before you get there, I mean, well, I think maybe, and maybe this is about whatever testimonies Sarah gets you, but is this the settings that are in existing statute and that you're adding birth center to? So the previous provision in that same statute too.
I don't think they had a problem with
You wanted to strike all of these settings.
midwifery services,
I
right?
have a problem with midwifery services generally, but the and provided in a hospital, birth center, other healthcare facility, or at home, she said, looking at this language, had them looking, actually revisiting under, the existing statute, and they wanted you to take those out because there's something to do with the contracting as well, but
So then
Maybe
they're
they'll-
already in there.
Is it a period after practice?
maybe we will just see their written testimony and see what it is that they're suggesting, because I don't know how to. I think so, but.
Yeah.
All right, so now we have CON. And the suggestion from the Green Mountain Care Board that makes sense to me, if you're gonna keep an exemption or exclusion for birth centers, is to put them in their own subsection and not tack them onto this existing exclusion for practitioners' offices.
Does anyone have any strong feelings about, not where it should go, like Jen is suggesting, but does anyone have strong feelings that we should maintain that birth centers have to go through CON? Or is everyone in agreement, like the Green Mountain Care Board and all the witnesses we've heard from, that birth centers should be exempt from the CON process?
I thought she said that they would support accepting CON.
Yes, she did.
That's what you said, right?
Yeah.
So
I think all witnesses that we heard from were in support of exempting them from the CON.
And in turn, no one has requested that we apply a CON to them.
Right.
No, other than perhaps maybe the chair of household care. But I agree.
The witness I meant, I'm sorry.
Do you have a reason for it?
I just, I have this thing in my head of, the fact that we raised the financial levels, that it won't really, and then I thought, well, we could maybe do an exception around the transfer, because that was a big thing. But let's face it, I don't think anyone is going to build a $10 million facility that can only provide low risk.
One or two.
And I just feel like that's not ever going to be an issue in the future of Vermont. And maybe if it becomes that, then somebody else can
Get rid of the,
can get rid of it, can modify it. It's not a problem now. And they're already going to be exempt under the financial,
Should that pass?
should that pass.
Although,
Even probably still with the existing levels,
and I will say the Senate is very concerned about, I've been telling them in the context of them working on the CON bill about what you're considering here. So there's some significant interest, at least on Senate Health and Welfare, in having an exemption.
an exemption, okay. I do think with rising construction costs, it's not long before 10 million is not gonna be a lot to build a facility, because concrete's price is like tripled.
Okay, they're in.
I'm just saying, it's like-
Indexed.
It's indexed.
Okay, oh, what does that mean? Like it'll.
It'll go up with, it historically has gone up with the consumer price index.
Okay. That's good to know,
Some
because
authority for the Green Mountain Care Board.
prices are
So
skyrocketing.
what's 10 million today, in 2 years could be 20 million.
Oh, exactly, exactly.
That much, but yeah.
You never know.
All right,
Okay, so everybody's in agreement that we should
I'm gonna move it to everybody. Okay, I move it.
Move it.
Own section.
to the best.
Standalone, okay. Great.
Great.
And I have,
Transfer of ownership.
As long as it's not
So
chapter
we don't need to
107.
worry about transfer of ownership now, because we are exempting them from the certificate of need process.
Yes, that's great.
So,
Good job.
great.
and there's one more change that I'm aware of from DEVA. that just wanted to take out the specific date by which of this July 1st, when they would need to request approval for Medicaid coverage. They would like to be able to be a bit more flexible and nimble about when they
Yes,
submit that request. So just take out the date.
More realistic.
yes. We're just gonna take it.
I'm struggling, I mean, it would be easy.
Not with this.
No.
I mean, I know they're really busy and I know all that jazz, but what if it never gets done? Because there's,
Which
They
they've
will
done
try.
They will try.
Yeah,
They're applying for something to the federal government. The federal government can take a year. It can take
Or just never do it
5
at
years.
this point. Who knows what's gonna happen?
yeah,
I
I
think
get
there's
that, and that's what I'm
concern
worried about.
That if they
Well, we
apply
have-
now, it will be rejected.
Yeah, even if they apply by July 1st, if the federal government dismantles these programs as is being suggested, it's not gonna matter anyway, so. I'd
I
rather
think
give
we
the
should,
staff
I think we
freedom.
should let them apply when they feel it is
Yeah.
the best time
Yeah.
to apply.
Could we do a no later then?
no, I.
What would be the point, though? We're gonna be back in January, so it's like in 6 months from that date, we're gonna be back anyway. If they haven't done it by January 1st, we can ask them why they haven't done it, but I don't see why we'd force them to do it if they don't think it makes sense.
Well, it's not in statute, we can ask them forever, but I mean, I get it, but I just worry that Medicaid coverage won't happen. Coverage for Medicaid birthing people at birth centers will never happen.
Even Medicaid.
Given what you have heard about the costs.
Yeah.
The comparative costs, there's an incentive for them to.
Oh, it's cheaper, you're saying? Mhm.
Yes.
If Medicaid
And don't
lives.
forget that CMS has guidelines around birthing centers and that is, they have, I feel as though we should trust our agency of
Yeah.
human services, who administers our state Medicaid and requests for federal approval. And I think that we should trust them to do it in the time that they feel it needs to be done, to the best of their ability.
Think
What about the rules part of that? I mean, take out everything after the date as well?
No, we're just removing the date.
Just removing the date.
So thinking that the rules might be done in a year, then they would have to have that application done by the time the rules are done.
No, it takes effect on the later of approval and takes effect on the later of the date.
Okay, so the rules
Rules
could be
take
done for a
effect.
year, but then they'll sit around until we get, okay.
Well, the Medicaid piece won't start until we get approval. But if we get approval before the rules take effect, then it can't happen until the rules.
No, I
take
get it,
effect.
but I'm saying that the rules could be done, but it might take a whole nother year after that in order to get through CM. Because they haven't applied.
Yes, but
That's
meanwhile, you can have birth centers beginning to open and operate and take insurance and.
Just not Medicaid.
Just not Medicaid.
Okay, if people are willing to do that.
Okay, so Jen's gonna work on these changes.
Thank you,
And
guys.
we do have you in here tomorrow at 9.
That may not be realistic,
Didn't.
just based on the need to collaborate with people.
That's what I was thinking. Well, I had you in here at 9 for a possible vote, but I did
Yes.
say that I didn't think that that would be possible, given all the changes that were going to be made.
I'll try to bring at least some language to you in the morning and walk into. And if I can, yeah, I have to look at how some of it looks, and we're still waiting for, I think, some cross testimony to see what exactly they're suggesting and. Yes, so I will work on moving something forward. Meanwhile, I have also heard back on S30 from the publisher who says an earlier date than January 1st would be good. So that we don't have to lay out two versions of everything.
Should we just say effective on passage?
I wouldn't do it effective on passage. I think you need a clear date. But I suggested maybe September 1st, and they thought that could, or September 1st or earlier is what she said. But I would like to run that by DFR and the stakeholders, just in case it freaks anybody out, or we need to put in a transitional provision of some sort.
Okay, so maybe we can have a possible vote on S30 tomorrow.
That sounds
Because
excellent.
it would be easier for you to change the date and have us vote on the,
Yeah,
Yeah, it'd be easier to have it all in one amendment. You don't have to
Yes.
we do on the floor.
Um,
And if we need to put in some sort of additional transitional language.
all right, so we still have you tomorrow morning at 9.
They'll have me tomorrow morning at 9. I'm here from 9 to 9:45, then I'm downstairs for a few minutes, and then I think I'm just back with you all morning. So
Okay,
I may be sitting over there working on some of this.
Thank you
okay.
so much.
Thank you, Jen.
Yeah, thanks, Jen.
So we're gonna start at 9 AM anyways. Walk through what Jen's been able to accomplish overnight, which I'm sure will be significant. No. I'm not saying that with any sarcasm. I am sure that it will be significant. And then we'll see if we can get, and then we'll possibly vote, and if not, we'll try to schedule later in the day, votes. Okay?
So we'll do S30 tomorrow too.
Yeah,
Thank God.
S3 and S18.
Only because I feel like we've done enough today and it would be good to have a breath.
Right.
But can I ask a question for real?
Is it something that we need to ask?
Maybe, I don't know, you can always say no after I ask it.
Okay.
No, I didn't get the 10 April Fool's joke, I kind of think, but, I know, that's fine. I'm just trying to formulate the question simply. Do people really want me to do S30? Because if so, I'm gonna start preparing before we vote it out of committee, because it's such a long bill and it's a lot to just understand, even though it doesn't really change a lot. If that makes sense.
I was going to make the suggestion that,
And no one else really wants to do it, right? No one's like jonesing to do a technical correction. Okay, I'm gonna just study up to do it. I'm gonna start because I wanna make it interesting and that's gonna take work, so.
okay.
All right,
Thank